especially these kids.
Yes.
They can code on you very quickly if you don't resuscitate.
Tell 100 stories of little kiddos that were sick and ended up being sepsis, some sort of an infection.
You are listening to EMS with your hosts, Erik and Matt Ball.
What's our topic today, Enrique?
Yeah, I think that today's a commonly missed thing, but a common thing we see. You'll have a baby that's just not feeding well or seems more tired or lethargic, it's not acting right. Missing sepsis is a common cause of a sick kid. Yeah. And a scary patient, when you see a sick kid, it's a lifeless sack of potatoes. It's scary.
Yeah. And we don't normally think, at least I didn't normally think of, when I thought of sepsis, you always kind of think of the older nursing home patient. Yeah. That's like the typical patient that pops into your head. Not the, like you said, young, lethargic kid. You're thinking sepsis isn't one of the first things on your brain.
That's right.
And it should be. It should be one of your differentials for sure.
And the younger like neonates, like little kids, they're almost. I mean, you should consider them immunocompromised.
Yeah.
So there's a lot of different factors to a sick kid. So so we're going to talk about pediatric sepsis.
Reminds me of The Office when Dwight says that I never get sick. Well, if you never get sick, then you have no antibodies.
That's
So that's like, I mean, literally, because little kids, they have no antibodies, right? Because they haven't really been exposed to anything.
Didn't he say something about like if he could have a superpower, he'd want to lower his cholesterol or something like that?
Well, he had one thing where he was like, I can raise and lower my blood pressure at will. Why would you want to raise your blood pressure? So I can lower it. Classic
funny.
show.
That's classic.
Anyway, you have no antibodies, Dwight.
No. And then we need antibodies.
Yep.
But, with sepsis, the adults get a lot of and like you mentioned, the nursing home patients.
Yes.
They get all the press.
Yes. And they're the most common, for sure.
They are the most common. But, the problem with kids, too, they can't communicate.
Right.
And they can't tell you, I'm having, feeling body aches or, and so they can go for a while. And because the kiddos compensate so well, sometimes we're not seeing them until they've fallen off the edge.
Right.
So we titled this lecture, a Tiny Human's Massive Compensation.
This is a podcast, not a lecture.
Sorry, podcast.
You're in lecture mode.
No lecture. Lecture's a bad word.
It's a curse word in the firehouse.
So pretty common.
Yeah.
You probably can tell 100 stories of little kiddos that were sick and ended up being sepsis, some sort of an infection. Mm-hmm. I think it's good to set the stage with, the most common kinds of infections that kiddos get. Yeah. Either bladder, lung, or skin. Yep. And skin would include ears and throat and stuff like that.
I'm going to default to respiratory every time, though.
Yes.
Just because, to me, that's probably the one that's going to, I hate to say kill them the fastest, but that's the one I'm going to be most concerned with. Yeah. Is the kid having that respiratory compromise and be real aggressive with the treatment. And that's what we teach, all of our providers. But like you said, they compromise really well. Right, but then when they don't have the reserves, and once they fall off the cliff, they fall off the cliff. There's no, slow roll into circling the drain.
When you have a really sick kid, we can support their respiratory system by giving them some supplemental oxygen, even intubating and breathing for them. Yep. We can fill their tank a bit with some fluids. Yep. Even in some municipalities will give antibiotics to treat the underlying cause. Yep. Lungs very common. Mm-hmm. One of the ones that we will miss, but in the pre-hospital environment, you're not going to test the urine, but a urinary tract infection is very common, especially with the kiddo that's potty training and learning how to wipe and all. It's really easy to cross-contaminate. Sure. Much more common in females than males, of course, anatomically, but those are the ones that I know in the ER can, you get this kid that comes in with a fever and vomiting. It's amazing how often it's a urinary tract infection. Mm-hmm. So it's certainly common, but in the ambulance though, you get called to a kiddo that's not doing well, fever, whatever the call is.
Difficulty breathing. Yeah.
Those are relatively common calls, but it's going to be one of those things. Yeah. It's 99% of the time. And then that small percentage of the time you're dealing with, and we'll talk a little bit about them, but like meningitis or maybe even some sort of a GI emergency, like appendicitis or something like
right.
that.
Unless they have some congenital thing going on.
That's true too.
Which again, like we talk about in all of our pediatric stuff, talk to mom and dad.
Yep.
They're the experts on what's going on with this kid. Get a good history because, like you said, the patient can't tell you anything. Obviously if they're 4 or 5, but if they're, babies 1, 2, they're not going to be telling you what's going on.
No.
Right? They're probably not going to be very happy. They're maybe going to be crying. If they're not crying, obviously is a good sign. They're not crying. They're very lethargic. That's a bad sign.
Bad sign.
Ask mom, how long has this been going on? Ask about diapers.
Yeah.
Fever. Have you been giving Tylenol and Motrin? Because you might check a fever and the kid doesn't have one. And then you take sepsis off your diagnosis. Yeah. Well, mom just gave some Tylenol before you got there. That's why maybe the kid's afebrile now.
And a lot of these immunocompromised folks can't even mount a fever. So, a fever is not a requirement for sepsis. It could be hypothermia as well. So that's a good point.
Just the presence or presumed source of infection is how our protocols are worded.
Yep. And the other big part of it is the compensation. Mm-hmm. So, I think this might be a good place to remind our friends, what is the definition of sepsis? It's when the body can't meet the demands. Well, that's really septic shock, I guess, is we can't meet the demands.
It's a cascade.
Yeah. The cellular demands of our body. Right. But sepsis, by definition, would be it's really more about the body's response to an invasion.
It's like anaphylaxis.
Exactly.
It's I've always said it's like using a nuclear bomb to blow up an anthill in your backyard. Yep. That's a little overkill. You
killed the ants, but
you killed the ants, but you killed the rest of the area too.
Right.
Yeah, it's overkill, right? It's again like an anaphylactic response. Yeah. It's its body basically attacking itself, and it's like, whoa, slow down.
COVID was a great example of this. You get the coronavirus in, triggers your immune system, and it's a respiratory virus, so it attaches to the respiratory epithelium. And then it creates this massive cytokine storm in the body. You end up, you got World War III taking place on that one cell thick, respiratory mucosa or the alveoli, right? Mm-hmm. And it creates damage, inflammation, and that's really what killed people was the loss of respiratory function. Yep. And you're not able to do gas exchange, you don't do well. So, but with no exception with kids, when you in sepsis, your body's immune system creates a lot of problems, and those problems are manifest by what we see on the vitals. Yep. So which is important to know, like what are the normal vitals? Because you got a neonate, it's not going to have a resting heart rate like a 50-year-old. That's right.
It's going to be a lot faster.
Yep.
And so that's why it's important to know what are those normal ranges, right? A neonate, little kid, their heart rate's going to be 150, 160.
It's normal.
That's normal.
That's right.
That's,
You and me?
Yeah.
Not normal.
If I'm at 160, take me to the hospital. If I've either done a really bad workout and I'm about to die anyway. But like you put that kid, like their respiratory rate's going to be like in the 30s probably, right? So look at the kid, and we'll talk about the pediatric assessment triangle or ABCs, I like to say it. But, look at how the kid's presenting. Yep. And look at everything in context, know what the normal vital ranges are for that age kid, and then you'll know if you're outside of that. Yep. It's important.
And kiddos don't have a lot of the same compensation capabilities of an adult either with that little heart of theirs, that young heart. They really, and we've talked about this with adults too. The first thing you see that changes is the heart rate. But they really have a limited ability to vary their stroke volume. It's all heart rate.
It's all speed.
That's right. Yeah. So that's important to recognize. So when you get that kiddo that's not looking so good, knowing what the normal vitals for that age kid should be. I mean, a 12-year-old's getting close to being an adult, so you're looking for those
more normal,
typical adult vital signs. But you got the neonate, you could have a heart rate, like you said, 160, and that's actually pretty dang normal. Yeah. So it's nothing to worry
about. Breathing 30 times a minute, like, okay, we're good.
Yeah.
Yeah, but like asking mom, what does the kid look like? Again, you get a 1-year-old, that's always a red flag that if, you got 5 people walking into a house swooping this kid up and that kid doesn't get mad and ticked off and start crying, that's kind of scary.
That's a really good point, is what does the kid look like from the door? Yeah. Is this kid
appearance?
Yeah, what's the appearance? And we'll talk about that with assessment with the pediatric assessment triangle. But there's a crying kid is a really healthy kid. It may be a little scary if you were new, like, oh no, this kid's crying. This is
got to be something wrong.
Bad. But a more experienced paramedic's going to know. I mean, that could be a problem there, but very well could be. That's another thing I love about kids. They don't lie.
Yeah, yes.
Something's bothering them.
Yes.
It might just be you.
Yes. Yeah. Yes. Might not be a medical thing. Might be an emotional thing.
Right.
This gigantic 6'6", 250-pound guy picking me up. Like,
we're monsters to these things.
Yes.
We're
in weird
person.
Well, and I was going to say, they don't know us, right? No kid goes easily typically to somebody they don't know, especially when they don't feel good, right? They want mom, they want dad, they want somebody that's familiar, comforting them. You hand them off. So when I was in paramedic school, and I went to paramedic school, we were down in the basement of this building. Those of you in Dallas know exactly which school I'm talking about. But we would go up for lunch. They had a little cafeteria. We'd go up for lunch, and then we'd go back down in the basement to do class. And I was in class all day. My wife knew, like, I was in class, and the cell signal was hard to get in this building. Well, anyway, I had gone up, and I got signal, and I had all these messages from my wife and missed phone calls. Very unusual. I knew, like, oh, there's something's wrong. And our youngest daughter was, like, 6 days old, I think, at the time. She had just been born. And so I'm like, okay, something's wrong. Call my wife. I'm like, what's going on? She's in the ambulance going to the hospital.
Oh, no.
And I'm like, what's happening? And she's like, she wasn't feeding. She was real lethargic. Excuse me. She's like, I didn't know what to do. I'm like, call 911. That's what we're here for, right? So they were heading to the hospital. Luckily, it wasn't sepsis. It was actually acid reflux that had got her.
Okay.
But it was just a scary thing. Little kid, scary deal.
6 days old.
6 days old, little tiny little baby. Nobody wants that call, this fragile little thing,
And they can turn quick.
Yeah, exactly.
You got to be preemptive with them.
Yeah. You got to be aggressive. You got to be on your game, paying attention. You have to be really good. It's like veterinarians. They're such good doctors because none of their patients can talk to them. None of their patients can talk to them. Think about that.
Yeah.
They have to go based on if they don't do a good assessment, if they're not really looking and listening and touching and feeling, it's hard to know what's going on, right?
I agree, and I think emergency medicine too is whether you're in the ER or an ambulance. A lot of our sickest patients, it's like veterinary medicine. Yeah, our physical exam, our history is so important.
Yes,
patient's not going to talk to you and tell you anything.
No.
You gotta pick it up.
Yeah, if they're unconscious, they're not saying much.
Yeah.
Yeah.
Fortunately, we have parents with these patients that are hopefully helpful.
Yes.
But that's a big part of it. And I think to finish off compensation, and you actually mentioned the respiratory system, and that's it doesn't matter where the problem is, where the infection is. That's part of the diagnosis of sepsis, but we depend so heavily upon our lungs to oxygenate the blood, to maintain the oxygen carrying capacity, to fuel the cells to do what they need to do. The lungs become a very important part. So when you have a little kid and the lungs are diseased or having the infection or whatever, maybe pneumonia, it hampers the body's ability to do what it needs to do, and they're breathing fast, their heart's going crazy.
And it's just this cycle that's getting worse.
Yes. Yeah. And so eventually they get lethargic when they just get behind. They can't compensate. Yeah. And kids compensate, and then they fall off a cliff. Yeah. That's just the pattern for them. Whereas adults, you'll see them turn a corner and slowly decompensate.
Yes.
I mean, everybody's different, but that's typically what we see.
You're going to definitely see a slower progression with adults than you will with kids.
Right.
So, when you go on these kids, keep sepsis as a differential, and then be looking at your kid. Like, do they look cyanotic? Yep. Get them on some oxygen. Be aggressive with that oxygen therapy. Yep. I don't like to start IVs on kids unless I have to.
That's a good thing.
But if I have to, I will for sure.
Yep.
And so you got to get that IV, and get some fluids going on those kids, whatever your local protocols.
And the fluids are so fundamental. We got to recognize when they're in shock, and it doesn't necessarily mean that the fluids are going to fix it. It's just gonna help them to perfuse. Yeah, that's right. And we got to fill up the tank. Yeah. And now we used to just dump fluids on people. That's not so much in the literature anymore. I mean, we may get to pressors sooner, but it's really important for kids though to recognize the signs of sepsis or septic shock before they decompensate. In little kids, you can look for retractions. That's actually even before that with the history. A couple things you can look for. You can ask mom, how many wet diapers?
Yeah.
Because if you're not making urine,
yes,
your body's reabsorbing and because it's behind.
Yes.
So
and you got to think they got little tiny bladders, so they're peeing a lot.
yes.
So if they don't have 8 to 10 wet diapers over the last 12 hours, that's probably low.
That's a problem.
Oh, they've only had 1 or 2 wet diapers all day.
Yep.
Okay, that's
It's not a diagnosis, but it's certainly, remember, that's one of the red flags.
Yes.
Mom says not feeding well. Yeah, normally she'll breastfeed, blah, 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 a number of times.
Crazy. Yeah.
She's just not, she won't eat. Yep. That's another problem with kiddos, especially the little ones, is they really are mouth breathers, right? And if they've
like
got
firemen.
Yeah. Knuckle draggers. Yeah, no.
Just kidding.
So when you're feeding,
yeah,
and you're not breathing well, it requires them to breathe through their nose, right. and if they're not able to do that for whatever reason, right. they won't feed, and then they're not getting the nutrition, and again, it just adds to the whole constellation of sepsis and when they're going to decompensate.
Yes. Until that infection gets fixed,
right?
It's just going to keep cycling downward.
Yeah,
and so early recognition of that is important.
Really important, yeah. So in the ER, that's what I'm looking for. I'm asking these questions. How are they feeding? How many wet diapers? Are they up to date with their immunizations?
Oh, yeah, good question.
That's another good one to ask.
Yeah, because nowadays there's a lot of parents that are, and I'm not making any kind of a statement about vaccinations, but I'm just saying you have more parents now that are not getting their kids vaccinated for things that we've been vaccinating kids for decades. Yeah. And so, everybody's entitled to their opinion, but we're seeing things that we haven't seen in a long time that can cause these issues.
We've been benefiting from what's called herd immunity for a long time, where certain people decide they don't want to vaccinate. Well, they benefit from the herd, so to speak.
The herd doesn't
that is immunized, and so that we're not seeing these diseases because of the herd immunity. But as more and more people aren't vaccinated, we're seeing some of these diseases pop up that hadn't popped up historically for the last few decades. Yeah. So that's a good thing to ask, just to be aware, just so we're they're at risk for certain things. Yep. So that's a good thing to do with history. And then on physical exam, I think there are a few things. If it's a little tiny baby, the fontanelle is a great way to check the fluid in the tank. Yep. If it's sunken, it's not a good sign. If it's bulging, it's not a good sign. Right. So those are the things we want to.
Temperature, I would, for a neonate, I would be getting a rectal temp. Mm-hmm. If I was really concerned, I want to get that rectal temp. On that kid, make sure you use the red probe. They're correct for one.
It reminds me of our the pediatric fever lecture. We were measuring our temperature, but
you were measuring my temperature.
Yes,
sir.
I was. Yes.
Yeah, there's lots of different ways you can do that. I don't like the axillary ones.
Not
oral.
No, most of what we do in the ambulance isn't a real accurate way to get a temperature, but we do the best we can. Yeah.
And a lot of these kids, you can feel them. You pick them up, and you're like, man, this kid's hot. Yep. And then, too, mom's got them bundled up, because they feel like which I get it, that's comforting and soothing for the kid, right? Yeah. And it's soothing for mom, so.
Especially when you're dealing with a toddler that's saying, Mommy, I'm cold.
Yeah.
You're going to get some blankets. Well, when you feel cold, that's a fever coming on, right? Yes. Those chills are actually the body temperature going up. Yeah. You're pulling in heat from your environment. Your hypothalamus has said, let's raise the body temperature. Yeah. Which, again, I love to say this and educate parents, but maybe if you're hearing this, you could educate parents. A fever's not necessarily a bad thing.
No.
The fever,
the body doing its natural thing.
Not only does it hamper the foreign invader and make it tougher for them to multiply, it also ramps up your immune system, giving them more strength, so to speak, right, to do a more efficient job of fighting the disease. Yes. So you're giving your body the advantage with a fever.
But you don't want it to get too out of control.
No, that's true.
Yeah. Once it gets too high, you want to get that down.
Follow your protocols. But a lot of times folks will call. My firefighters will talk to me because I'll talk about fever, and then I'll get a call. Hey, Joey's got a temperature of 102. Okay, tell me more, right? Well, he's playing Legos right now, but should I do something about the fever? It's like, no.
He's
it's
playing
okay.
Legos.
He's playing Legos.
Yeah, exactly.
Same temperature, same kiddo.
Lethargic.
Hasn't eaten all day.
Yes.
Can't sleep at night.
Red flag.
Give him the Tylenol.
Yes.
Give him the Motrin. I know there's some controversy with some of these meds, but get them comfortable so they can eat and sleep. I think the risk-benefit there is certainly in the favor of the kiddo, 100%. Getting some rest and sleep and food, nutrition.
That's how the body heals.
Yeah. Yep. Also on physical exam, we can look for, in addition to the temperature, we could get to more vitals too, but is the retractions. You see retractions on a kiddo. Those are some belly breathing. That will, progress to costal retractions.
Tracheal tugging.
Yes, you get to the tracheal tugging or the sternal notching or whatever you want to call it. That's progressed retractions.
Cap refill.
Yeah.
Like, look at them. Look at the core.
Cap refill's huge.
It's huge. Yeah.
Huge.
Look at the core. Do what you can do. Cap refill on their skin. Everybody goes to the fingers or the toes. Like, do it on their chest. Do it on their abdomen. See if you get that return of color. But yeah, if you have a slow cap refill, I mean, I look at that more than SpO2 on a kid.
Yep.
I mean, because it's quick, right? I can look at that quick and go, how well is this kid perfusing?
That's why it's such an important part of the pediatric assessment triangle. The perfusion is huge, especially in sepsis.
Yeah.
Because when the body's compensating, it will shunt body blood to the core. You get that mottled kind of cool extremity, But you got to be careful though, because if you really go into full distributive shock, you've lost the ability to vasoconstrict. So the extremities don't have to be cold, and that's when you're really in trouble.
Yes.
Now your body's not compensating,
moving a little bit faster.
Yes.
Yeah.
Yes.
That's where you're starting the IV on the kid. You're getting them on supplemental oxygen.
Yep.
Yeah, you're definitely moving down that road a little bit faster. Circulation, we talked about that. We talked about breathing, and then appearance. Again, if that kid's not crying, if they're lethargic, those are all red flags.
I would say that I think that's not given enough credit. That doorway assessment. When you're looking at that kid, you can see a lot there. And I think differentiating between sick and not sick is really what we're talking about here. But that vital sign of just appearance is huge. And again, that's on the pediatric assessment triangle. That's why it's there. It's a big deal.
Yeah.
Is that kid tracking and looking at you? They should be a little leery of you and a little shy. I mean, that's normal. Maybe even cry when you go to put on the blood pressure cuff or even the pulse ox, right?
Yep.
They should be fighting you. They really should be.
You. Yeah.
They
don't
do not.
touch me.
That's scary.
Yeah.
And then, gosh, let alone an IV. If that kiddo's not crying with, I mean, there's that kiddo's having issues.
Also, blood sugars.
Blood sugar.
Check that. I mean, we're kind of touching on vital signs. Check that blood sugar, because these kids don't have a lot of reserves, glucose reserves.
Yep.
So you want to check that sugar, make sure if they need a little supplementation, get that sugar on board to give them energy, right, to fight through this infection that they're dealing with.
And I'm glad you mentioned that, because this is another thing, to not, you see a kid with potential sepsis. It's good to dig deeper. Don't just anchor on the fact we got sepsis. Yeah. There are some things that can cause a rapid respiratory rate in a kiddo that looks sick. That's not sepsis too. Yeah. Checking that blood sugar, and it reads high in this kid who just, we find out, he's got a type 1, he's type 1 diabetic. But parents didn't know that. Yeah. But you got the kid that's breathing fast, and it ends up being a totally different disease process, which is oftentimes actually triggered by viral infections. Viral infections, like you have an initial viral infection, and then the body and the immune system end up attacking the pancreas, and it's a common cause for type 1 diabetes. Yep. So it's that's not sepsis, of course, but it can sure look like sepsis.
Sure,
absolutely.
Sure. And the treatment's kind of going to be the same, right? We're going to control the airway, fluids, right? We're going to give some fluids for a kid that's hyperglycemic, and we're going to transport probably to a children's facility if we have that ability to do so, and obviously following our protocols. For I'm going to always go to somewhere where that kid can be admitted. Yeah. Because whether it's sepsis or if it's new onset diabetes, they're probably going to get admitted and be there for a few days.
Probably ICU as well.
Yes.
Well, so as we talk more about assessment, right, and trying to figure out what's going to put a kid at risk for having sepsis. Well, the little tiny neonates, like we talked about, they have an underdeveloped immune system, and even the blood-brain barrier is not quite right. They're going to get a full workup when they get to the ER. Those kiddos can be very sick. Yeah. They're immunocompromised, like we talked about. Yep. Some of the kids we see are chronically ill, too, and they're immunocompromised because of some of their medications that they're on. So being aware of some of these things with medical history is important. Some of these little kids have DKA. Diabetes already, right? So an infection can actually trigger a more life-threatening problem of DKA. Commonly, that will be triggered by that. So those are things to be aware of, I think, the risks. I think there's all sorts of different pediatric diseases that can increase the risk for that. But I think overall, being aware of all of the history that we talked about, putting yourself in a position where you're not going to miss a pediatric septic.
Yeah, I think just again, if I went back 5 years ago, I probably wouldn't have sepsis on my differential going to a pediatric call.
Yeah.
Right? Because again, you're thinking more the older nursing home patient. That's going to
Exactly.
be, as soon as I get a sick person call at a nursing home, that's like number one.
Yep.
Not even on there with a kid. So it's one of the things to change, have that on there, even going to a difficulty breathing or something like that. Hey, they could be septic.
Yeah.
Keep that in mind.
And I think another risk factor as part of our assessment would be the fact that these little kids, because of their body surface area to mass ratio is being off, they're really kind of hindered as far as thermoregulation goes.
Yeah.
You and I can thermoregulate pretty easily, but a little kiddo can't do it as well as
Big
we
old
can.
heads.
Not as efficient.
Yeah.
So that's another issue. But I think if you're looking at a kid and you're trying to remember all this stuff, it can be a little overwhelming. But just remember the triangle.
Yeah.
Pediatric assessment triangle.
Yep.
Really, that's an easy thing to
ABCs.
remember. ABCs.
Airway, breathing, circulation, right? Or appearance, breathing, circulation. Sorry.
Well, it's like the
Not
ABCs.
airway.
You're right. I mean,
Yeah.
that's all. I think that's kind of plays in this too.
Yes.
But you're right. So as far as the appearance, first thing we look at from the doorway, you're looking at the kiddo, a crying kid that's fighting you
That's a
or
good sign.
the mom. Good sign.
Yeah.
They tracking. It's normal for a toddler to be crying and fighting you, but a tiny little baby or maybe an adolescent kid, there's
Probably don't know the difference.
right.
Yeah. But then you're looking at, again, cyanosis.
Yeah.
Are they nice and pink? Right? What's their cap refill?
Good.
Definitely throw them on the SpO2, see what that is, right? Listen to lung sounds, right?
Yeah. Work
Listen to
breathing.
their heart. Does their heart sound like it's ticking good? Again, remember your normal vital signs.
Yep. And work and breathing with retractions.
Yep.
How hard are they? You can see that from the doorway too.
Yep.
And you said that color of the skin, perfusion. I mean, you can see that from the door. A lot of these things are not rocket science.
Right.
We just cannot forget to understand how important it is to identify a pediatric septic patient.
So we get this kid, we figure out this is probably sepsis, right? What are you doing for this kid?
Well, I think the first thing, and I think one of the hardest things to do is like, how sick are they? Do they really need an IV or not?
Right.
One of the cornerstones for treatment for us in the ambulance will be, obviously, regardless of whether you're BLS or ALS, but I mean, we need to get them some fluids. These kiddos can get dehydrated pretty quick. So if you have a patient that you feel like you need to give them some IV fluids to help them to compensate, they're going to need an IV.
Just get the IV.
Yep.
Explain it to mom, dad, whoever's there. Hey, look, we got to get this IV on this kid. Hands, in my experience, are going to be probably your best bet on a kiddo. Usually AC, you might be able to get one. Those are they're not going to usually have the forearm veins.
Depending on the kiddos.
Depending
age,
on the kiddo, yeah. Usually hands are the go-to spot.
Yeah.
Make sure you board it because they might rip that thing out.
And if you need to, we got the IO.
We do have the IO. Yeah,
Yeah.
that's going to be we need IV access now.
I mean, you're thinking these are those kids. I mean, if you're going to go into cardiac arrest, and we've talked about this in some of our other lectures, the number one cause for cardiac arrest in kids is respiratory.
Yep.
And if you're in a situation where you've got that kind of a kid, don't hesitate.
No. So it's better than waiting and working a cardiac arrest. Yeah.
Yeah, distal femur.
I was going to say, hopefully most protocols have distal femurs, not tibias anymore.
Yeah.
I would hope so. I mean, tibias, if that's all you can get, but you should be able to get a femur on a kid. No problem.
So I think the fluids is big, and knowing, follow your protocols for how much fluid to give. And there's all sorts of different, thought processes on this.
Yeah.
But a good rule of thumb, if you look at it depends. If you've got Broslow or Antevi, you're going to be able to get a pretty good idea of what they're going to need.
Right.
And again, depending upon the size, because these are weight-based fluids, right?
Ideal body weight.
Right. You're not throwing a liter on everybody.
No. Yeah, exactly. Exactly. Yeah. Remember your 1, 3, 5, 7, 9, 10, 15, 20, 25, 30. That's a quick down and dirty way to remember what the ideal body weight for a kid of that age is. And so, give them a fluid bolus, again, depending on their size.
Yeah.
Give them a little bit of fluids. Get them on some supplemental oxygen. Maybe some end tidal. If you can get a little end tidal on there, see what their end tidal's at.
That's really good.
Yeah, that would be a helpful tool to have.
And I would say, as you're making these decisions in the ambulance and you're looking at a kiddo that's tachycardic, but the blood pressure is normal.
That's compensation.
Right. We've talked about that with adults where oh, well, the blood pressure's still normal, so we're probably early in the shock progression. But with kids, because they can compensate for so long, if you see a kid that's hypotensive now, you're behind the 8 ball.
Right.
So don't wait for hypotension.
Yes.
You've got to use your clinical sense to know that this kiddo's not doing well, is going to need fluids. Give it to them before they're hypotensive.
Age times 2 plus 70. Remember that.
Yep. That's good.
What is it? Yeah, everybody says a little bit different, but yeah, you're not looking for a blood pressure of 120 over 80.
No, you can't.
Basically, if you have a pediatric patient and their blood pressure is less than 70, you've got issues.
Right.
Yeah.
And then don't forget too about mental status. Listen to mom when she tells you her child is not acting right.
Yeah.
They may not be able to talk to you and tell you who the president is or how many quarters are on a dollar, all these questions we might ask for mental status, obviously. But listening to mom, she'll know.
Yep.
She'll know. And this is true, I think, too, with those chronically ill kiddos, that they may be chronologically 12 years old, but, developmentally they're 6 months.
Yeah.
Those children, too, they can't communicate with you, but mom can.
Yeah.
And said, no, normally Joey, when he's happy, he does this. He's not doing that.
He eats 5 times a day.
Right.
He hasn't eaten at all today. Yeah.
And I think that we've had other talks on this, but when you have those chronically ill kids, depending on mom and dad and the history that they give, that's a huge part of it. But sometimes we tend to be really scared with these types of patients, and then we immediately think, okay, let's get an IV. We're gonna have to get to the pediatric hospital.
More often than not, I would say, let's just go.
Yeah.
Let's just go to the hospital.
Right,
just go.
Right.
Yeah.
But these kids, talk to mom and dad. It's like you'll hear from them. No. I think Joey's okay. I've seen him much sicker. It sounds to me like this could be another one of his ear infections, or often you'd be surprised.
Yeah.
A chronically ill kid with a G tube can also have an ear infection, and so anyway, so we don't want to be just because they're chronically ill with a G tube or whatever.
It's this horrible.
Exactly.
Thing. Yeah.
So now we're going to intubate them and put in the IO.
Confirmation bias.
Yeah. Yeah. So I think that's important. Get a full history.
I always take
very
mom.
Well may need it. So.
I always take mom with me, mom or dad.
Yeah.
I always take them with me because too, you get that kid in the back of the ambulance without mom or dad, they're not going to be very happy.
No.
So, and mom and dad's probably not going to be very happy that they're not with their kid. And I'm when my kids were little, you're not transporting my kid without me. Yeah. We're going to be there. So it's always better to take mom and dad. Obviously, do that safely, but take them with you. Keeps the kid calm. A lot of times, especially if it's a baby, I'll give mom, if they need supplemental oxygen, give her that non-rebreather. Hey, hold this up to their face, that blow by. It gives mom a job, will kind of calm her down a little bit, and boy, they will be diligent about making sure that mask is right where it needs to be.
I'm glad you brought that. You reminded me of something so important and so common with RSV.
Yeah.
We got to keep these kids calm.
Oh, yeah.
You start to agitate them too much and do too much, it's just going to create a bunch of problems.
Yeah.
The faster that kiddo moves air, crying, getting freaked out,
screaming,
the worse the problem and the barking becomes.
Yeah.
But you keep them calm, moving the air relatively slow because they're with mom and mom's arms, you're going to be able to get that transport safe.
I would say that's the best way to do it, no matter what. Because obviously this is not a good day for the kid if they're riding to the hospital in an ambulance.
No.
So they're going to be freaked out no matter what.
Yeah.
So having mom or dad there, caregiver, whoever it is there, is going to help the situation, right?
The RSV situation is the only time as an ER physician I don't like them freaking out, and I try to do everything I can to calm them down.
Calm,
Where most of the time,
do you just tell them to calm down?
Yeah, right.
Calm down.
Calm down.
That works so good with my wife.
If they calm down, it's so helpful with RSV.
Yeah.
Some of these other respiratory issues. But when it's most of the other things, when I see a crying kid, I'm like, let him fuss.
Oh, yeah,
That's
let
great.
him scream.
Right.
Yeah.
No, with RSV.
Yeah, no.
Yeah, no, I like to let's find a way to calm them down.
Yeah.
And get mom in there. Well, like you said.
Yeah.
All that stuff. That's really important.
All right. So we did assessment. Talked a little bit about treatment.
Yep. We
Anything
talked
else
about
you
fluids.
When would you intubate? When would you make the decision to intubate one of these patients?
Well, I think that now this
What are
is
some factors you'd look at, I guess?
Yeah, I think being able to assess whether or not they're protecting their own airway. You get a kiddo that's so lethargic, they're just literally like a sack of potatoes.
Almost totally unconscious.
Yeah, you need to take their airway.
Yeah.
Let's get them resuscitated, and then eventually they'll gain the mental function.
What do you
again.
mean get them resuscitated?
Well, yeah.
Go deeper.
Well, we go really deep on that.
Well, yeah, but I mean, I think that's important for people that have the ability, for departments or agencies that have the ability to RSI and take patients' airways. I think it's very important to understand it's not all about like resuscitate before you intubate.
Absolutely.
And especially these kids.
Yes.
They can code on you very quickly if you don't resuscitate.
Yeah, that's right. If you want to have a post-intubation collapse,
Yeah.
then, you don't want to mess with that.
SpO2,
Getting the fluids
blood
going.
Yep.
Absolutely.
Pressures.
Yep.
And SpO2, got to get those sats up. Don't really want to be satting a kid or you don't want to be tubing a kid that's in the 80s.
No.
Got to get those sats up.
That's good. Resuscitate before you intubate. Yeah,
Yes.
Thank you. That's good. And I think another common thing as we're managing these kids is that this isn't a load and go situation. I think it's important. I mean, we're going to be transporting these kids, but do what you need to do now. Especially with some of the things that we need to do in the ER, we can do it here. Getting it done quicker is better for those kids.
I think it depends too on where you're at. Like if you're in a rural environment, because we always say, you and I work in a kind of an urban area, right, where we're 10 minutes from 4 different hospitals, right?
That's true, yeah.
But if you're out in the middle of Wyoming.
Let's get started. Or
yeah.
maybe in a helicopter.
Or in a helicopter, and
right.
you've got an hour-long flight back to the children's center in wherever, you need to get going.
Yep.
Excuse me, because time is of the essence. And you can do these interventions en route. You need to be able to start an IV en route. You can give fluids en route, pressors en route. Hopefully you're not intubating en route, but I mean, it definitely depends on your location. If you're an hour out from that facility, obviously, if your kid's that unstable that you're taking an airway, I would assume your protocols tell you to go to the closest facility, because even a small ER with one physician and a nurse has more capabilities than we have in the back of an ambulance.
Correct.
And so take them to anywhere, especially you're not in the back of a moving ambulance. You're in a somewhat stable environment. They can get them tubed, they can get them stabilized, and maybe fly them out if that's what's called for. So I think we always say like load and go or stay and play. There's different ways to say that. Really, a lot of that depends on where you're at.
Yeah,
if you're 5 minutes from a hospital, stay, get that IV. Make sure you get your best opportunity. If you need to tube the kid, get the fluids, all that kind of stuff, and then start heading to the hospital because you're close. You got an hour-long transport. We don't have that time. I can't spend 20 minutes on scene and then drive for an hour.
That's true.
Anyway.
And I think a lot of times crews, and I've felt it before, even in the ER. You just kind of want to get them out of the ER quickly.
You want to get them out of your ambulance.
Exactly.
Yeah, I want to get out of here. This is not comfortable.
But there are some times, especially I think more with cardiac arrest, which we're not really talking about today, is important to get that stuff done.
Well, cardiac arrest is different because there's nothing that you're going to do in the hospital for that kid that I can't do. I mean, as a paramedic, right, that I can't do. There's same meds, all that kind of stuff. I can intubate, all that. So we know that working that problem on scene is better for the kid.
Right.
But when you've got a sick kid that needs antibiotics or whatever they need, ventilatory support.
You can do that en route.
You can do a lot of that. If your protocols allow you to. Yeah.
And I think deciding how to transport to, you mentioned the helicopter. I mean, you've got that's a tough decision to make. When do I pull the trigger for this? Yeah. I know for me, in the way that I've trained up our guys, and some of the places I'm medical director are really out there. An hour-long transport's not uncommon.
Yeah.
And making that decision on whether or not we fly, it can take some thought.
Sure.
And sometimes they'll call for online medical control.
Yeah.
Well, and I encourage them too. I said, if you're not sure,
call me.
Call them.
Yeah.
So
call the helicopter or call you.
Call me.
Yeah.
Yeah. Call me, and then we make the decision together.
Yeah.
Yeah. And if they did call a helicopter and they were wrong, there's usually, like we've talked about before, there's a context to this. There was a decision that was made for a reason.
Thought you were doing the right thing for your patient.
Yeah, do something for a reason.
Never wrong in that.
Yeah, so just don't do it because you're scared.
Yeah, exactly. That's not a valid fear.
Yeah,
we think that this kid needs to get to this facility quicker.
Yeah.
That's the quickest way to do it. That's why we call the helicopter.
Yeah.
Done.
So before we go over some common cases, I thought it would be good to mention, too, one of the common problems, and again, difficulties with managing pediatric kiddos is the dosing errors. Because these meds that we treat with, whatever medication, like if it was a seizure or something or whatever, I mean, we're going to be giving it medications. We got to measure them out by weight, weight dosed meds. this is when it becomes all the more important to do things correctly.
Yes.
That's where Antevi comes in, right? With the
yes,
system.
we are not sponsored at all. We are friends with Dr. Antevi, but we are not compensated in any way, which is totally fine. But that app is a phenomenal app. Takes all the guesswork out of it. That's the whole reason why he created it. And it just works fantastic. It's just a fantastic app. I can't promote that app enough, and I'll promote it for free till the day that I die, because it truly, my paramedics are like, this is the greatest thing we've ever gotten. I've used it. I love it. It just works.
It takes something off, like you said, the checklist.
The fear.
It's like it's gone. Yeah, the fear's gone.
The fear of making a mistake. Yeah.
It's like this, okay, I can put my mental energy into these things.
Yes.
Right. I don't have to worry about the math here.
But if you don't have Antevi, let me give you a down and dirty way of drug calculations.
Let's see.
I am not a math guy. You're a brilliant math guy. My dad's a brilliant math guy. My father-in-law's. I'm surrounded by brilliant math people, and I can hardly spell math. So it's simple, right? You figure out the weight in kilos.
Yeah.
Okay. You figure that weight out, and then you take your desired dose over your volume on hand. Okay, Matt, what do you mean? Okay, what's my desired dose? I need, and I'll tell you exactly the call that I went on with this. Went on a call, pediatric seizure call, showed up. Because it was an 18-month-old, everybody automatically went into, it's got to be febrile, right? So the trucker, whatever it was, got there first. We showed up on the ambulance afterwards, and one of the medics is holding the kid, drawing a bath, getting ready to put this kid in a cooling bath. And I'm thinking, okay, it was febrile. So what was the temp? It was 98. Did the kid have a fever beforehand? Like, was there a, nope. I'm like, okay, well, then this isn't febrile. The kid is having another, it's not a febrile seizure, right?
We need some benzos.
Yeah, we got to get this kid some meds, right? So, again, got confirmation bias, got anchored on this. So, got the kid out to the med unit. Kid starts seizing. I never had an 18-month-old seize on me before. Now I got to figure out, oh, crap, how much Versed do I draw up? Because that was the drug that we used at the time. And now I'm having to do math. And now I'm scared because I don't like math. And how much does the kid weigh? And I'm like, okay. And I had, in nursing school, I had a nurse break this down. This is very simple. So your desired dose is whatever your dose is. You do the kilograms, whatever your protocol calls for, right? So let's say your dose is 5 milligrams, that you need to give to the kid, okay, based on your protocols. And then let's say that you have Versed, and it's 10 milligrams in 2 mLs. Doesn't matter what the medication is. Figure the concentration down to 1 ml. How many milligrams, micrograms, grams, or whatever it is.
Per ml.
Figure it down to 1 ml. So if you've got 10 and 2, that means you've got 5 and 1, right? 5 milligrams
concentration
per ml, right? So then you just take my desired dose is 5 milligrams divided by the volume on hand, which is 5, right? 5 divided by 5 gives you 1. I need to give 1 ml because at the end of the day, it doesn't matter what my dose is. I need to know how much do I need to draw up. I can figure out the dose. I still need to know how much to draw up, right? So it doesn't, you take any number. If the kid needs 3 divided by 5, that'll tell you the volume you need to draw. 1.2 milligrams, 1.2 divided by 5, that'll tell you the volume you need to draw up. You can do that pull out your phone, figure out your dose, figure out the concentration down to 1 ml, plug the desired dose into the volume on hand. That'll tell you the volume you need to draw up every single time. As soon as I found that out, I wanted to smack my paramedic school instructors. Like, why didn't you teach us this from day one? Like dimensional analysis and all this. Like, what are we doing? Teach us this easy stuff. So hopefully you have an app like Antevi, and Broslo will tell you the dose, per the weight.
by height, actually.
By height, yes. It'll still, but it'll tell you how much you need to, but it'll just tell you the milligram dose. So you take that dose, get your concentration out, figure out how much you got per ml, do the math, and you're good. And it takes the scariness out of it.
And that's what I like about Peter's system.
It's already prefigured.
This is done.
It's done.
Broslo, they compared the weight-based versus height-based. It's no statistical difference. There may be some new studies out now that show that Peter's stuff is better. I don't know, but
it's better in my opinion.
Yeah, I agree too. And with your hand, you've got hands.
Yes.
It's just a beautiful part of the system.
Yeah, it's very simple.
Yeah. So anyway, I think that's something to consider when you have that pediatric kiddo. Have a plan.
Yep.
Be familiar with
be
your
thinking
system.
about those dosages beforehand. Okay, we've got, your notes will probably tell you it's a 1-year-old, a 3-year-old, or whatever. Okay, be thinking, okay, if we got to give this kid Epi, if we got to give this kid Versed or Ativan or whatever, right? What's my dose? Like, be ready for the worst case scenario on this kid.
Yeah.
They start season, here's my dose. Boom, I can give it right away. Especially if you're giving an IM dose.
Yeah.
You've got it ready.
Absolutely. That's easy.
Sorry, I'll get off my soapbox.
I think that's a big part, and that's, again, why I think we're at risk for mistakes and causing harm.
Because you're scared.
Do the math. Yeah, you're
You
scared.
can reduce fear through education.
And it's one of those low-frequency, high-risk type patients. So that's important.
Reduce your fear through education.
I don't think there's a lot more as far as treatment goes. I mean, if you guys, if you can use antibiotics, that can be something you can give.
Yep.
Fluids.
Yep. Pressors if you need to control
There's
the airway.
airway support too. There's some other things you can do. Supplemental oxygen.
Yep. About that.
And then transport.
Yeah.
To the appropriate facility.
If you got to resuscitate before, you got that patient that's maybe a little bit difficult to get their sats up with. Remember, these kids are breathing fast enough. They just it's not a ventilation problem. It's an oxygenation problem, right?
Yeah.
So get that supplemental oxygen going. Get a high flow, nasal cannula on them, depending on the age of the kid. Give them a lot of oxygen. Get that nitrogen washout on those kids is going to buy you time when you go to tube these kiddos.
Yeah. And I don't think we can say it enough how the pitfall of just thinking a kid looks okay. They look okay. Well, they'll be fine.
Yeah.
They will crump on you fast.
Yes. Oh, their heart rate's fine. Their blood pressure's fine. Yeah, now.
Yeah.
Wait 5 minutes. Might not be. Yeah. So be ready for that crumping kid.
So I think one of the common cases, I think one of the most common ones for me, I would say maybe that toddler that's been sick for a while, been in and out of urgent cares in the middle of the night, is not acting right, and mom calls 911, and then brings them into me right at 2 a.m. or whatever. Yep. So you're the paramedic on scene. You see this 2-year-old
sticking his head in the freezer. It's croup.
Well, actually, it's funny that sometimes these kids look so sick at home. I've seen it. My kids have been that way. Yeah. You get them into the outside in the cold air and things.
They feel better.
Yeah. But you get this kiddo, again, a very sick kid. The first thing you're going to do is that pediatric assessment triangle, right? You're going to get a good history, obviously, while maybe working together with your team. But what does the kiddo look like? What's the appearance? As you look at him, wow, this kid doesn't look right. They look like they're just limp in mom's arms, and right. In fact, not too long ago in the hospital, I had a mom just brought in a 3-year-old just limp in her arms, totally unresponsive.
That's lovely.
It's like you don't know, like, what is this, right?
Yeah, did they get into something? Is this an overdose? Christmas Day, I was on shift, and we had brought in the entire Lord of the Rings trilogy. Yes, I'm a Lord of the Rings nerd. I don't care. I love that movie.
I do too.
It's my favorite. It's my favorite movie trilogy of all time.
That sound, anytime they talk about the Shire, that music they play.
Oh yeah.
This makes me feel like
I actually listen to that on YouTube.
Oh yeah.
They actually have. Anyway,
calm me down.
Totally geeking. It's very soothing. Anyway.
Did you ever read the books?
I have read the books. Yeah,
yes.
Tolkien.
Oh,
yeah. I have one of a Tolkien quote tattooed on me.
How did I not know this?
Yeah, not all who wander are lost.
Oh yeah.
Yeah, that is a Tolkien quote from the Lord of the Rings.
That is right.
Anyway, so
we should do a podcast just on Lord of the Rings.
Dude,
I love those.
Let's
movies.
do it.
Go
Christmas Day, we were on shift. It was but I had brought in the Lord that we had planned. We were going to eat good. We were going to watch movies as much as we could. If we didn't get any calls, it's hit or miss. I've worked Christmases where we're just running nonstop, and then this Christmas happened to be relatively slow. Actually, it was very slow. We were watching these movies afternoon. We're sitting there fat and happy, bunch of firemen, Christmas Day, watching a movie, and the doorbell at the fire station rings. And so we're thinking it's somebody to come by, because people will come by and bring us treats or whatever. And I remember I walked around to the door and I looked through the window into our vestibule, and I see this guy holding this lifeless kid in his arms. Oh, the kid was he was maybe 5 or 6. He wasn't a baby. And I just thought, the kid looked dead. Yeah. And I just thought, oh, dear God, please no. Not a dead kid on Christmas. Yeah. Please, not for this family, not for us, not for anybody. Yeah. And he was a postictal. He had a seizure. Okay. And they lived very close, so they got freaked out.
That's what that 3-year-old was in the ER.
Same thing.
Me.
Yeah.
Same thing. Sorry,
but no, it's just, I'll never forget that call because I'll never forget as soon as I turned the corner, I saw this guy holding this kid. I thought, I thought the kid was dead, and I just
Yeah.
thought, oh God, please not on Christmas.
Yeah.
Please don't do that to us.
Yeah.
That would be terrible. Luckily, it was just a seizure. Kid was fine, but
the 3-year-old patient that I mentioned earlier, those are those patients banging on the ambulance bay doors, right?
yeah, freaking
There's
out.
always something interesting that's coming in.
At 2 in the morning, especially.
Yeah.
Yeah.
So you're seeing the sick kid. You go through your pediatric assessment trial. You're looking at the appearance of the kid. You're looking at the work of breathing. You're looking at their perfusion. Looking at the skin. Is it mottled? You know. Anyway, I think that's so important. That first step. Stay calm.
Yes, that's a big key. You're going to be freaking out. Take a breath.
Yeah.
You start freaking out. Everybody else around you is going to freak out. Act like you've been there before. Mom and dad are certainly going to start freaking out.
Yeah.
Reassure mom and dad. Now we have our visual assessment on this kid.
Yeah.
Now we're going to mom
Yeah.
or dad,
Get some
whoever the
good
caretaker
history.
is. Yes.
Exactly.
What's going on?
And while you're getting history, your partner's getting some vitals.
Hopefully.
We want to gather information.
Yes,
Get some information.
as much as you can. Blood sugar.
Yes.
Get them on the heart rate monitor if you can.
Yeah. Get the
Listen to
temperature.
lung sounds.
Yep.
Get the temp. Get a rectal temp if you
Yeah.
can, if it's appropriate, right?
Yep.
But talk to mom. Mom, how long has this been going on? Check the fontanelles.
Yep.
That on the
Yep.
peds.
On
But
the little neonates.
how long has this been going on? Oh, just, whatever, a couple days.
Right.
Have they had a fever? Okay. Have you been giving meds for the fever? Have they ever had this before? Do they have any medical problems? Are they diabetic?
What's the urine output? How many wet
Yes.
diapers?
How many
How
wet
are they
diapers?
feeding?
How are they feeding?
Are they vaccinated? All these questions.
Yes. Yes.
Once you get a good history and a good assessment, a good physical exam, then you can move forward and think and even discuss with your team, right? Well, why don't we work on getting some IV access? This looks like one of those kids that's going to need some fluids. This kiddo's sick. Or maybe they're not so sick, right? No IV, guys. Let's load. Let's get them to the hospital as quick as we can.
Do you know what a beer
Let's
trail
put mom
set
in the
is?
back. Yeah, go ahead.
Do you know what a beer trail set is?
No.
Yeah, I didn't know either. We were talking earlier about fluid boluses on
Yes,
kids.
yes, yes.
That's what you use to give the appropriate amount of fluids to the kids. It's a little beer trail set you hook up to your IV bag.
Okay.
Yeah, we did a video on it, or I did a video on it one
I've-
time. But
I've never
a lot
used
of people have those. We
Yeah.
have them in the ambulance, and I'm sure the nurses,
Yeah.
right? Because as the doctor, you're probably not setting up the beer trail set, but.
Yeah.
A lot of people, when I remember going through an ambulance, like, what the heck does this thing do?
Yeah.
And that's what it's for. You fill up the appropriate amount of fluids, and it drips that much.
Yeah. Yeah, when we get a sick kid in the ER dropped on a trauma bay somewhere and just undifferentiated, mom's standing in the back of the room freaked out. She doesn't know what's going on. We'll get history from her, of course, but I think just staying calm and remember we got to gather information. Now, if you're in a situation with you clearly see an airway emergency potential,
Got to deal with that first.
deal with that first.
Yeah.
But gather information, and if it is that pediatric seizure patient, right? If you don't get that history, you might be intubating somebody that was in 20 minutes would have been totally normal.
Correct.
So anyway, it's a tough situation to be in.
Yeah.
But with pediatric sepsis in particular, like the case we started, being able to get the information in a calm manner, confident, right? You're gonna be able to appropriately treat that kid, transport them to the appropriate facility where they can get what they need.
Yep.
The problems is when we don't identify these things and we see, and I've been a victim of this too, where you see a kid that's breathing fast and you think it's a panic attack, or it's this 10-year-old kid at school.
This little neonate baby's having a panic attack.
Yeah, right. I was on a call with our firefighters. We had a call to local middle school. I can't remember how old this kid was, maybe 12 or something like that. And she was just freaking out, right? And breathing fast, non-cooperative, just looked really, really sick. That same patient could be a panic attack, or it could be flora DKA. I mean, it could be a lot of things.
Thyroid storm.
Yes. Yeah, hopefully not. But yeah, no, you're right, though. I mean, it could be a lot of things.
Yeah.
Keeping the blinders off.
Yep.
Right. Really keep your mind up, especially
Just get
with
as much
kids.
information as you can get, right? Obviously, we're limited on the amount of diagnostic tools we have in the back of an ambulance, but again, check a blood sugar, check a temperature, get a blood pressure, get a heart rate, listen to lung sounds, like do all these things. Get as much history as you can from mom.
Yep.
Look the kid over, head to toe, see if there's anything there. Heck, it might be a hair tourniquet. You never know.
That's right.
You know, we actually recently had a pediatric case in.
Did you? Because we just talked about this.
What?
Did you get one? A
No,
hair tourniquet?
no, we did not. I did not get
Oh,
one,
oh.
but it was in
Didn't
my
we just talk
differentials.
about this?
Yeah, well, we've talked about it several times before.
yeah,
But
okay.
it was actually one of my medics that brought it up to me. Was because the kid was crying, like kind of unconsolable, right?
Yeah, yeah.
And he looked at me and he was like, "Have you thought about it? Have you looked for a hair tourniquet?" And I was like, "No," but because we had just got there, whatever.
Yeah.
But I was like so proud of him because he had said that. I was like, there's not many paramedics that know about that.
Cool.
He knew it because of, I think it was his son or something had one. And so now he had that experience stuck in his brain. Unconsolable kid.
Oh, that's cool.
Check everywhere. That's all I'll say.
Look in the pants and look at the feet.
Yep.
Yeah,
yep.
That's
anyway.
So I think the key takeaways today.
We bounced.
This is a tough patient sometimes and easily to miss. And the things that we do in the hospital, in the ambulance matter, especially with pediatric sepsis patients. Yeah. And then the transport decisions we make matter. All these things matter. Yep. But I think the key takeaways, I don't know if I'm imagining I'm talking to all my FTOs right now. Like, what would I want them to know? Or if you're a new paramedic or EMT, what would I want you to know? Well, how important the vitals are. I mean, well, actually,
your assessment.
The assessment first.
The whole
assessment
thing.
history is huge. Yes. Understanding that the vitals on kids are different at different ages, but understanding how important it is to recognize when things aren't right. Yeah. Because if the blood pressure is off, you're behind the 8 ball. Yeah. Tachycardia is so important. Yes. And understanding that too. And then I think not only is blood pressure a late sign, but then just to remember too, is that early recognition of sepsis, and this is universal. Early recognition is what saves lives. That's what decreases mortality. Yep. Is delayed recognition is what kills people. That's right. Especially little kids.
Yeah. Add it to your differential. Have it on there when you're going on these calls. So, good topic.
Be safe out there.
See you on the next one. Wait, we did that backwards.
We did the backwards. Okay.
Oh, well.
Doesn't matter.
Next time.
That was fun.
Thank you for listening to EMS, the Erik and Matt Show.